GP clinical lead for North West London for maternity, children and young people, and absolutely delighted to be joined by Stephen Goldring, a consultant paediatrician and London CYP asthma lead, and also by Amuntha and Tonya, who are going to talk to us about how Whips Cross are working collaboratively using their 48-hour review pilot to improve the health and well-being of children with asthma. We'll follow up these sessions with a Q&A. We will be collating questions throughout, so please post anything that's of interest or any queries that you have. And as I say, we will endeavour to answer them at the end. But without further ado, I will hand over now to Stephen, who will tell us all about childhood asthma and update. Stephen, you just need to come off mute. Apologies, Stephen, we can't hear you at the moment. Can I check Adam or Nima if anyone would be able to help Stephen with the sound?
So I think Stephen had an echo. Is he on the call? I'm just checking if he's on the call still, because I think we did advise that he drops out and comes back in again. So I'm just seeing if he's back on the call.
I think he's here now.
Okay, I think we're good.
Thanks, Stephen. Yes.
Yeah, sorry, I had a really bad echo. Right, so I take it you're controlling the slides for me.
Yeah, I am.
Perfect. Okay, so thanks very much. And thanks very much for the invite. Really nice to be here and to be part of the Ask About Asthma campaign week, which I think I've been in there since the beginning, and I always enjoy it and always learn a lot. I'm going to talk about asthma in primary care. I have no disclosures. I will be talking quite a lot about Symbicort at the end of this session, but it's not because I have any pecuniary interest. It's just all the evidence is only with Symbicort that I'm referring to. And a little plug on the front of slide here. The QR code you can see is for Tier 3 asthma training. And I've only got 20 minutes. There's no way I can cover everything you need to know about asthma in that short period. So what I say, if there are things that I'm signposting you to, you really need to get the Tier 2 or the Tier 3 asthma training done. It's absolutely fantastic, and we'll cover all the things that I can't cover in here. Okay, next slide, please. So key messages from me. Well, childhood asthma is common and children still die of it. And sadly, we've had some deaths in North West London, and I've looked at those, and it's heartbreaking when things could have been done in hindsight. Asthma attacks are sentinel events that something's wrong. Something needs to change. And if that change doesn't lead to an improvement, then you've got to refer, and somebody else has got to dig deeper and work out what the problem is. You've got to keep going until you've resolved those concerns. And two particular updates is the concept of the anti-inflammatory reliever. This is a new era in prescribing, and I think over the next few years we're going to see this more and more, the use of the anti-inflammatory reliever, and I'm going to go through that. And I want to give an update on post-attack weaning plans, which are now in the dustbin of history. Okay, next slide, please. So the statistics are really clear-cut that we have terrible outcomes in the UK. The left-hand side shows mortality by international comparison, and this is all summarised in the National Review of Asthma Deaths, which is nearly 10 years ago now, where things are just going wrong so badly. And the key message from that is we have to take asthma seriously, and you have to take each attack seriously. Next slide, please. Now, in this Ask About Asthma campaign, the wider determinants have been flagged up as being really important, and absolutely that is right. These two cases tell us why. It's so tragic. Ella's a little girl who died of asthma, but through a long process, the coroner made legal history by putting air pollution as the cause of death. And of course, that's what's driving so much change in terms of how we use our cars, and it's terribly important. And we need to be having conversations with families about air pollution in our practice. It's difficult to get that going. It doesn't quite feel natural to us yet. And I think during this week, think about how you can build in those conversations with families. On the right-hand side is Awab. This is a little boy that died of mold-related respiratory disease in Rochdale. And his death has led to the government to pursue Awab's law, which is going through now. And this is really about there being greater legal responsibility for landlords to address unsatisfactory housing. And boy, you know, we know how bad a problem housing is, particularly across the country. And, you know, you see how upset families get when they live. They show you photographs of their bedroom being so moldy and damp ridden. And we've got to take action. We should be writing letters of support. And my sort of easiest piece of quick advice is to recommend that families contact the Citizens Advice Bureau, because this is becoming a legal issue, and the Citizens Advice Bureau is really good at giving legal advice and helping parents to word letters if landlords aren't being as helpful as they should be. Next slide, please. So, asthma definition. What is asthma? Well, if you get that picture of a child who gets recurrent symptoms of wheezing, cough, difficulty breathing, chest tightness, and they tell you that it happens when they exercise, when they have a cold in the winter, when it's winter they get colds, they're always chesty, tight. The salbutamol helps, relieves those symptoms. Oh yeah, and when it's the pollen season and the grass comes out and they play football, they get a lot of pollen-related symptoms. And if you can combine that history with variation on peak flow, actually, you've got diagnosis. That's asthma. And if you can support it because you've got access to spirometry and exhaled nitric oxide, even better. On the left-hand side are 3 lung tubes. And I use these whenever I am talking to families about asthma. I've got some physical copies. They're really, really, really helpful. I'd recommend getting hold of them or using these diagrams. And first thing I'll say to parents is, well, look, which of these tubes is the easiest one to breathe through? And, you know, they smile and they point to the right one. And then I say, well, why is it difficult to breathe through the other ones? And the first thing is, well, obviously it's swollen in the middle of a tube, and that's the inflammation. And right, that's right. It's the inhaled steroids that treat that part of the problem, okay? And that's why they're the most important medicine. And then I point out, and people don't notice this, on the right-hand side, you can see the smooth muscles have also constricted. And you can say, when you have an asthma attack, what's happening is a trigger is making the smooth muscle constrict. And that's where the salbutamol, your blue inhaler, helps. And that's why that one feels like it does something. But it does not get to the root cause of the problem. It does nothing about that inner inflammation. And that's why it's so important you take your inhalers. And I think that kind of level of conversation, that concept is really important early on when you're talking to families. Next slide, please. It's just showing us the triggers which we're familiar with. It's useful to have a kind of idea of the kind of different pollens through the year and the other triggers that maybe manifest at home or in the environment. Next slide. This is just a slide of those signs to look out for. They give you more confidence in the diagnosis of asthma when you see a child who's clearly atopic. Denny Morgan folds underneath the eyes, in the eyelids of allergic rhinitis. Eczema. The allergic salute, which parents are so familiar with, their children rubbing their noses. They rub them so much they get a horizontal crease across their nose. Often that's from dust mite allergy, which is a driver for asthma. And then the bottom right, you've got a child who's had an allergic reaction. Of course, you can have non-atopic asthma. So just in the absence of these doesn't mean to say it cannot be asthma, but the presence makes it much more likely. Next slide, please. Do you think about alternative diagnosis, symptoms from birth, chronic wet cough, failure to thrive, sudden onset like this poor child here with X-ray, or in the older child, perhaps they've got an isolated brassy cough, no real true wheezing, and paresthesia, pins and needles and hyperventilation with acute attacks, and salbutamol hurt straight away within seconds, which is characteristic of dysfunctional breathing and panic attacks. Next slide, please. Okay, so this is not much of an update. The update is that we aren't there yet with diagnostic testing in primary care, sadly. The guidelines tell us that we should be using objective testing, but I suspect North West London is similar to other ICSs, and we don't have a universal system where GPs can access spirometry and pheno at a kind of universal level and in a timely way. Because you have to remember that the tests, because asthma is a variable condition, if you perform a test when the child is well or they're on treatment, you'll get a false negative. So you really want to have quick access to these tests for them to be meaningful. But spirometry, very useful, peak flow, best of 3 twice a day for 2 weeks, extremely helpful. Can be done in primary care, and more than 20% variability is a positive test. And I'd strongly recommend you do this before you start a trial of any treatment in an age-appropriate child. It's helpful that the National Asthma Bundle, which has been going for a couple of years now, has acknowledged that where objective testing is not possible, the diagnosis should be based on clinical judgment and a response to trial of treatment. Next slide, please. And that's why a lot of the time when I speak to GPs and we're going through diagnostic testing, I refer to the BTS algorithm. If you just press next slide, it'll pick up a high probability of asthma. When you've got that lovely history, as I kind of talked about a few minutes ago, actually that's very likely to be asthma. And you should be starting after peak flow testing, a trial of treatment, trial of inhaled steroids, teach them how to use their inhaler, and review them in 6 to 8 weeks' time and check the response. If you're in the middle group, the intermediate probability or the low probability, I suggest you discuss with your local asthma services and your PCN leads about how you approach that and whether you're going to go down a trial of treatment first and then review, or all those children should be referred. That's probably a local decision. The intermediate group, if they're well, probably still lend themselves to a trial of treatment, but then you definitely need to refer. Next slide, please. Okay, I love this slide because it really illustrates what happens to children and adults when you start inhaled steroids in a steroid naive patient. You can see on the left at the beginning, they've got this lovely peak flow variability ranging from 300 to 700. They then start their inhaled steroids and you can see how it all narrows down. And by week 3, and certainly by week 7, that variability in their peak flow has gone. They will then be feeling symptomatically better. They will be sleeping well at night. They won't be coughing through their night. The parents will come back and they will say, oh, you know, that really worked. That really helped. It's made all the difference. It's the first time he's gone for good night's sleep and we haven't been worrying about him. So that's a good response to a trial. And obviously, if you did the peak flow measurements at the beginning in, say, weeks, you know, -2 to 0, and then at the end, you'll see that difference. It also tells you in this slide that you do need to take your inhaled steroids regularly, and you've got to explain to the families this is a bit of a long-term game. but let's at least try it 2 puffs twice a day for the next 6 to 7 weeks and then review. If you can at least get them over that line to kind of come to a concordance where you and the patient are on the same page, but you're going to give it a really good go for 6 to 7 weeks, then that is like your first step. Next slide, please. And next. So I'm not going to go through a stepwise approach guideline because this will be in your local medicines management guideline, which I suspect will be a kind of combination of the NICE and BTS recommendations. And, you know, it talks you through step 1, 2, 3, etc. Next slide, please. What I want to focus on is actually that poor adherence is the biggest reason for treatment failure. So when you're looking at a patient who's on step 1 or 2 and things aren't working, the likelihood is they're not taking their medicine, okay? Now, the reasons and the barriers are manifold. I speak from personal experience: forgetfulness, chaotic lifestyle, poor supervision. No child should be expected to go up to their room and take their preventer inhaler every day without any supervision. They need to be directly observed. You have to be a very mature child who really takes their own health seriously to do that and be relied upon. So the parents need to be completely involved in watching them take their medication. Regimes can be seen as too complex, they don't want to be different, and there are many different reasons for poor adherence. And even in studies where you tell people, we're watching you take your medicine, adherence is terrible in 2/3, okay? So you can be assured that most of your patients are not taking their treatment. And of course, that means if you're trying to go from step 2 to step 3, where that means doubling the patient, twice nothing is still nothing, okay? Simple maths. Next slide, please. Okay. Background risk. So we're thinking about preventing attacks and preventing serious attacks. So you have to have in your mind a concept when you see a patient about what is their background risk of having a severe asthma attack. And this study is a systematic review looking at these different risk factors. And you can see right there at the top, the biggest is previous attacks. So you know that if a patient has had 2 asthma attacks, going to hospital, needing steroids, quite bad, the same will happen if you do nothing, okay? As short as, you know, one thing leads to another. The other risk factors that are flagging up: the child with persistent symptoms, not using their inhaled corticosteroids, poor access to care, and poor health kind of education and knowledge, comorbid atopy and allergy, and there are many others. And I also just want to flag up that if you've ever had a PICU admission for asthma, it really carries a long-term, and they say lifelong, risk of future severe asthma episodes. So one bad attack means more bad attacks. Next slide, please. The second concept is to get the idea of asthma control in the last 4 weeks. And that's the best way of assessing that is through the asthma control test. It takes about 3 minutes. I've got an app on my phone. It really is the best objective way of asking a patient about what their symptoms have been like over the last 4 weeks. And it's obviously reproducible when they come back for review. Next slide. So this is probably the most important slide of the talk. Your role or one of your key roles in primary care is the identification of uncontrolled asthma. Okay, and this isn't just something that happens when patients turn up for their asthma review. I realise cough has a certain, financial incentives to do certain things, but if we just think about what's good, what's right for the patients, we need to have proactive systems to identify uncontrolled asthma. And in the latest version of the National Asthma Bundle, this is a draft form, the concept of long-term management, where you're proactively actually looking through your register every 3 months I'm thinking about, okay, who's flagged up, who's had an attack, not waiting until they just happen to come through your door, but being proactive. That's really important. But these are the sorts of questions that you need to be asking. And I have to say, when I do clinics in primary care, and I do quite a few, I love the fact that I can go onto your electronic patient record, and before the patient comes into the room, I've reviewed all of this. So as they walk in, I'm already thinking, okay, this guy has got severe asthma or certainly uncontrolled asthma, and we've got to work out what the problem is. And then it's a lovely process of detective work with the family and the child to work out what the issue is. On the right, I've just flagged up the number of inhalers you might use in a year and what that equates to, which I think is really useful to have as information when you're reviewing records. And obviously, key thing to flag up: salbutamol use 4 inhalers a year is now the cutoff for thinking about this child needs to be reviewed. If they're actually getting through 4 inhalers, we know there'll be quite a few kids who will deposit them around their various family members, etc. But if they consume 4 inhalers in a year because they needed those puffs, because they're breathless moments, then you need to act on that. Next slide, please. Okay, let's get the basics right. Okay, when we see children for their annual review after an attack, opportunistic, make sure they've got an asthma action plan. We're 4 times less likely to have an asthma attack with an asthma action plan. If you don't know how to complete one or how to fill one in or where to find it, you need to do your e-learning for health tier training. Absolutely. Show me how you use your inhaler. Okay, that's the question. It's not just, do you use your inhaler or how do you use your inhaler? It's a visual. I want you to show me what you do. It cannot, I'm afraid, be done over the telephone. Okay, a phone check is really no good. It's video call or face-to-face. Otherwise, as this lady shows, it'll be all sorts of weird and wonderful techniques. Mentioned pollution there on the right, and those things at the bottom: address adherence, triggers, smoke, vaping exposure. Are there psychosocial safeguarding issues? Next slide, please. So you might be thinking, well, when do I refer these patients? And this is very important. And hopefully you'll have referral guidelines in your local ICS. But this is from the draft national bundle. I think 2 or more courses of steroids per year, 1 or more hospital admission, 4 or more SABA inhalers used per year, particularly when that's combined with attacks, recurrent symptoms with low ACT score, healthcare professional concern, parental concern. If you can't resolve those concerns, because obviously in primary care, there's loads of it you can do about this, and you should have the skills to start this work. And you may see a patient and think, okay, yeah, we've got a few things here, but actually they have no idea how to use their spacer. So I'm going to change that. I'm going to fix their inhaler technique. We've had a chat about adherence. I'm going to see them in 4 or 5 weeks' time. Go back. Okay, yeah, actually I'm happy now. Things are resolved. They're under control now. And you may be able to keep it within primary care. But if you can't, then you need to make a referral locally. Next slide, please.
Stephen, you've just got a couple more minutes left.
Yeah,
Thank
I'm
you.
really bad. Yeah. Very quickly, I just want to flag up the anti-inflammatory reliever, because this is a new era in medicines management. This is a 2-in-1 device. It contains budesonide, an inhaled steroid, and formoterol, which is a fast and long-acting beta-2 agonist. That means you can use it as a reliever, but it gives you long-acting relief. Brilliant evidence that this, for mild asthma, and I'm underlining mild asthma, is absolutely superior to using a salbutamol inhaler alone, controlling symptoms and preventing attacks, and is a safe alternative to daily inhaled steroids. So there are patients that I see who've had quite mild symptoms, using perhaps, every now and again, maybe a couple of times a year, I get a cold, just need to use my blue inhaler and maybe a bit of hay fever, and that's it. Not had any severe episodes. And the advice there on how to use: 1 inhalation is needed, not more than 6 on any single occasion. If you need more than 8 in a day, seek medical review. This is now, next slide, please. BTS guidance, next slide, is now in the GINA guideline, which is 2023. So if you're someone that wants to practice evidence-based medicine, then you need to work with your local pharmacists, or you may be a pharmacist in a position where you can influence, get this into your local treatment regime. Next slide. This is just to flag up about salbutamol weaning plans, which are really have gone now. This is a brilliant example from Beat Asthma, which is a fantastic resource, all sorts of useful things on there. When children have had asthma attacks now, what we would say, use your salbutamol as needed. You can use up to 6 puffs every 4 hours. If that's not working, you need to seek help. And if you're needing to use your inhaler after 48 hours, still needing it regularly, seek help. But the days of weaning down 10 puffs, then 8 puffs, then 6 puffs have gone. And that should be making its way into your local guideline. Next slide. So in summary, from a diagnosis point of view, be pragmatic. You must identify uncontrolled asthma and get the systems in place within your primary care network of your practice to get that in place and get the basics right. Not improving, refer. And I would implore everyone to get their e-learning done. This is going to be part of CQC shortly, so it must be done. Thanks very much.
Fantastic. Thank you. And it's so much information in there, and lots of queries in the chat as well, which we're collating. So thank you so much. And I know that everything from new advice around inhalers and equally really pragmatic tools, they're just so welcome. And we will be just sharing the slides, as we've said, in the chat, and also collating the questions and coming to those at the end of our next presentation. And so without further ado, I will hand over to Amintha and to Tonya, who will talk to us through the Whips Cross collaboration and their 48-hour pilot.
Thank you very much. Can I also ask Shiraz to turn your camera on, please? I see you there, or you can't hide from me. So there's 3 of us on the call today who've been part of this 48-hour review pilot in Waltham Forest over the last couple of years. I'm Tonya Myers. I'm a GP clinical lead for children and young people, and we've got Dr. Amutha and Panantha, who is consultant in paediatric emergency medicine, and just showing himself here is Dr. Shiraz Yunus, who is our clinical lead for the GP Federation in Waltham Forest. And so this pilot really fell out of a child death review outcomes in Waltham Forest. It was a very tragic case of an 11-year-old child who was known to everybody, including safeguarding, and still managed to die from an acute asthma attack. And one of the findings that was clear was that this child, as many others, had frequent attendances and had not been having 48-hour reviews. And so I'm going to credit Amutha there with coming up with this idea, because at that time the GP Federation was doing post-discharge reviews for frail elderly, and Amutha said, well, why couldn't they do children? And so this pilot had no funding, and a few innovative clinical leaders decided that there were some slots in the GP SPA that we could use for this. Now, as many of you will know who do clinical leadership, that there is a very slow process of getting business plans, getting funding, etc., and we'd been blocked for a very long time on there is no money in Waltham Forest. So therefore, this was created, and that model has as with Connecting for Children, it comes back to bite you later on sometimes, which it has done. But it enabled us to set it up with some people with a vision, and the reason for this, obviously, those of you all know that NICE guidance recommends a 48-hour review for children who attend DD with wheeze, but in primary care, GPs will often not get a discharge summary till way after 48 hours. They may not have read it. They certainly may not have actioned it. And parents have problems, even if they're told to go and see their GP at 48 hours and they've engaged with that, in access. So this is why we thought we would do this. And if, as it was in the GP Federation, it would be equitable. In other words, in GP networks, which came along later on, there are networks that some are better, there's variability, let's say, whereas this was offering a standard offer to all children. So I'm now going to pass over to Amutha. Now, we have loads of slides, Amutha, but not a lot of time. So I'm going to suggest that you just sort of race through them, pick out the important items, and one of the team are going to be controlling it. So over to Amutha, please.
Thank you very much. Can you all hear me? Because I'm having a bit of an IT issue. Excellent. Could I have the next slide, please? So you all know about Core 20+5. So what we hope our pilot is helping with is addressing the over-reliance on reliever medications, because we know children tend to ED having not controlled their chronic side of it. And main aim is decreasing the number of asthma attacks, because we were looking at reattendances through our emergency department. Next slide, please. So the main aim of our pilot was, does providing this 48-hour GP follow-up appointment reduce reattendance to ED? Next slide. So we looked at specific things, which is, we know that follow-up arrangements need to be made after every attendance. So we looked at the 48-hour follow-up with GP. We only looked at Waltham Forest patients. So Whipps Cross is surrounded by quite a few boroughs. We're only looking at one borough. Next. And as we said, we're using already 4 funded appointment slots, which weren't specific for us. And we wanted to specifically look at what happens when you put this pilot in. Next slide. So the process in ED, the patients present to ED, they're either seen in our emergency department and then put into our day unit to watch them respond to their treatment. Very few are actually admitted to the ward. They all get discharged, and then we've organised it so that we organise the GP Hub telephone consultation. So as they're discharged from ED or the ward, they are leaving with an appointment in their hand or a slip saying you'll be called within 48 or 72 hours to see how you're doing. And in the GP Hub itself, we've created or we've kind of put together a traffic light triage system of what to do next. Next slide. Within ED, and I'd like to share this because actually we do quite a lot of work, because these patients, once they get to us with an asthma or a wheeze exacerbation, they are with us for a good 3 to 4 hours while we see their response to the treatment. So we have time to go through some triggers and information giving as well. So we talk about smoking, and if they are smoking, we have a QMUL letter that tells them about the evidence and the importance of reducing smoking. We talk about relievers if we can. We talk about inhaler technique, and actually we have the opportunity to actually show them a technique and actually to watch parents give the inhalers as well. They leave with a written personalised plan, and we organise that GP follow-up, and of course community asthma nurse if they meet the referral criteria. Next slide. So we did a snapshot data in November to December 2021 to see if they're following our local guideline. And actually, it was very poor. As you can see, the percentages are all very low. It's difficult to know if it wasn't documented, it wasn't done. So we've done a lot of work within the department in the last 2 years, and these numbers are a lot better, purely with education. We do lots of one-to-one teaching as well, and our uptake on following the trust guidance is much better. So hopefully in primary care, you're also seeing that these patients are coming up with all of these already done. Next slide. We also managed to contact a few patients to see what the impact of this was. Next slide. And if we looked at these, of those who are actually, so not 100% of these patients should have got a GP Hub appointment, but they didn't. Again, that's internal. That's about us raising the awareness. We have a high turnover of staff and a lot of locum staff as well, as you do in emergency departments. So it's keeping the education and keeping the systems in place. But of those seen by the hub, everyone loved it because they're actually leaving the ED with an appointment. They don't have to wait in a queue elsewhere. They don't feel the anxiety of, oh, I've got to make an appointment while I'm looking after a child who's got wheeze. They loved it, and they all had telephone consultations booked for them. Next slide. Of the people who didn't get the hub, we know they've struggled to contact their own GP. But interestingly, of the 7 people who did see the hub, they were happy with the appointment, but actually they wanted to see their own GP. They wanted that family connection. They wanted that known person to review their child. We accepted that, but they did say that it was quicker to get this 48-hour hub through us. Next slide. So we developed with Shiraz's team and our asthma consultants in the hospital, and our asthma nurse, we created a triage form, which made it very easy to follow. Next slide. Hopefully the triage form is on there. Yes, I know it's small, but you will all get these slides. This is pretty much based on all the criteria, and it's been made to make it very easy for the person at the GP hubs to do a tick list, but also to kind of help them triage them very quickly. So red would be, actually, I'm going to refer you into ED. Yellow is, I'm not sure, we better do a face-to-face appointment. And green is, okay, you're fine. You follow on with your normal GP follow-up. Next slide. Okay, now this is a very busy slide. So this is the one that everyone needs to concentrate on. So we looked at 1 year's worth of data, and we were specifically looking at reattendances. So when we looked at 12 months back in 2021 to 2022, in the Whipps Cross Emergency Department, we had 1,708 attendances, which could be one patient with more than one attendance who came to the emergency department. Of that, only 33% actually had our GP hub. So that's internal. We've missed 77%, but this was the first year, so we had a lot of work to do internally. Why are we not hitting 100%? Just click one more. Now, this is important. Of the 1,708 attended, 168 re-attended. So why are these patients coming back? Is it because of their acute episode, we hadn't controlled it, or is it their chronic, acute on chronic that we're still not on top of? Just one click, please. Right. Again, very busy, lots of numbers, and you can interpret these numbers very differently. But if you look at, so the first one, the average reattendances was 34, and I would tell you that's October. October of every year, we have patients who come back who've been here before, and we're expecting that every year. We haven't done a deep dive into these individual patients yet to see why they keep coming back, but that's a big red flag for us. Next slide. So the 48-hour hub, so we looked at it differently. We looked at it of the patients who reattended, who had a GP hub. So the 168 patients who reattended, they received that 48-hour hub follow-up. 17 of them reattended within 7 days. Why did they reattend? We haven't done the deep dive, but that's something we need to look into. Is it they are not getting the right advice? Is it we triage them wrong at the GP hub? I mean, there are so many variables, and that's the next part of our work, is to have a deeper dive and see what is it that we have control of. And 24 of them reattended within 28 days. Again, is this the acute episode, or is this a second episode within 28 days? So we haven't done the part 2 of it, but that's what we're working towards. But what I really want everyone to take from this is we have a lot of attendances to ED and a lot of reattendances. What we have control of is once they get to ED, can we reduce the reattendances? Next slide. We also try and capture these patients and refer them on to our asthma nurses who are in our boroughs. At the time when we did this the first time, no referrals were being referred from our GP hub to the asthma nurse. Again, another piece of work that we're working together to try and kind of increase awareness and saying, look, 2 or more episodes, get them into asthma nurses so that they can do the deep dive if we don't have the time. And again, different boroughs, we're working on that. Next slide, please. So themes and learning, why are 100% not referred to 48-hour hub? We've looked at the ED process. We have, anecdotally, we're doing so much better. It's just become normal. Have they come in with a wheeze, on discharge, tick, 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 are we doing it? The GP hub at the moment, we only have 4 slots. Today already, I've been on since 9 o'clock. I've already had 5 patients with wheeze, and we're going to have to figure out where they're going to go, the 5th one. So it's a GP hub availability. It comes with funding. We're also looking at patients who are reattending. Is it poor compliance because they're already under specialists, or do the specialists not realise that they're coming in? Again, connecting all the primary care, secondary care people if they're needed, if they're involved already. And again, more appropriate asthma nurse referrals who do have the time to do the deep dive, to go and do home visits, to do all those things that we may not be able to do in the timeline that we have. Next slide. Next slide, please. So the phase 2 of it, which is what we're in at the moment, is we are looking for funding for someone to do a deeper dive in the data, try and capture those patients that we've not been able to capture in ED purely because we're busy or they've been missed by staff. Also, those patients missed from the GP hub, appropriate referral, continued training and awareness because of the high turnover of staff. We have a separate project on identifying frequent attenders, and I'm sure we're going to capture asthmatics and patients with wheeze who have missed. But also we need to decide, is face-to-face GP appointment more appropriate than a telephone consultation? And that's going to be part of our next project to see which one's better. And again, re-audit and comparing re-attendance data. That's what we need to look at. I think that's the last slide. Just one more. That's it. Shiraz, did you want to come in with anything from your experience?
And also Zara is on, I
amazing.
just noted. Zara's on. Zara, can you put yourself on camera? Who's our community asthma nurse? Thank you for joining us, Zara. Shiraz.
Yeah, no, thank you, and thank you, Amita. So, really fantastic highlight summary of a lot of work that's been going on in the background. And I think really what we want to try to describe is that whilst you have lots of pilots that can run on a shoestring, here we did not have a shoestring, so we're all literally giving a lot of time and effort to make this happen because it's really important. And what we have here is what we haven't had before, which is following the patient in their journey when they leave hospital and actually understanding the obstacles and the issues that they face, and that ultimately then leads to poor care of their asthma. So as Amita has said, there's lots of work still to do, the deep dives and trying to understand actually where the issues are and unpick the bottlenecks, but at least now we're following the patients through their journey, and that will definitely work towards making something much more better. So yeah, it's probably the main thing I wanted to add. Zara, my answer.
So I was just going to say some of the issues that have arisen. So now, once we're a year in, we wanted to get funding, particularly for the admin support for Shiraz and his team, because Shiraz, as our GP Federation lead, has numerous projects he's working on, and without adequate admin support, we can't do the audits and so forth. So we have a business case, but we're now in a catch-22 in the new ICB situation where you can't put a business case until you found your funding stream, and we can't identify a funding stream. So we have this, but we have got a couple of other projects that have been successfully funded on a non-recurring basis, including one we just recruited to in Amuta's department for a frequent attender pilot. So we've got a health visitor going to be working full-time in ED to support Amutha, looking at children who've attended 5 times or more in the last year, and a number of those will be asthma. So we're going to try and again sort of retrofit this new post into supporting the 48-hour review. And then we have our additional issues as that Shiraz's hub is only commissioned on a rolling basis, so we've only got 6 months, and then it might be pulled again, hopefully not. And one other very interesting development is the neighbouring borough, Redbridge, has got a little pilot going on, having their 48-hour reviews done by a nurse-led system in our paediatric assessment unit. So we're going to have an amazing possible double-blind trial whether the outcomes are better with a face-to-face nurse-led, assuming we have a bit of resource to do the research. So it's exciting times. And again, for Shiraz team, I'm very pleased to hear that CQC is going to be looking at at whether the training is appropriate, because the GPs are all locums, and so we need some quality assurance. It's not just how brilliant Shiraz's template is, which needs updating for its weaning plans. We've just worked that one out. Thank you very much, whoever spotted that. But it's there's lots of potential here, but it is very labour intensive. And also we have the support not only of Zara Rippington, who is our fantastic asthma community nurse in North East London. We have for a year two asthma practitioners, nurse practitioners, who are also supporting us and going to help with some training in the hub. So that's us. And I just want, so any questions? And Zara, if you wanted to add anything, I can't see you. Please do.
That's great, Tonya. Thank you so much. Zara, let me know if there were any final thoughts. But a massive, huge thank you to Amintha, Shiraz and Tonya for what is not only an inspirational but incredibly practical and impactful piece of work, which I think we're all looking at with envy, actually. But also thank you not only for sharing the learning, but also the challenges, because we know that there are many. Now, as time has gone on, we have been answering some of the questions in the chat, but have also collated a couple. So Stephen, I'd invite you to pop your camera back on if possible. And one of the recurrent themes, and I know that you've mentioned it, is around the templates and the weaning. So, and one of the early questions was, how is it that local trusts still mention weaning plans in the discharge letters, and particularly from ED has been highlighted. Amintha, Stephen, would you like to comment on that?
I can go for ED. So we're run by a trust, you know, which course is always a year behind everyone else, but we'll get there. So we were planning to start it in September, but we've just got a research project for the next month, and we are planning to launch it on the 1st of October. So for our local borough, I think everyone is just different time. I think if you look at the bigger scale, EDs are within a trust. They're waiting for their respiratory tertiary hospital to say it's okay. So by the time it filters through, and education, and even I guarantee in 1st of October there will be someone who's still being discharged on a weaning regime. It's all the local barriers. We have high turnover of staff. There's more barriers than everything else. So we will get there, and hopefully by December everyone will be there and education will be up there for everyone.
Yeah, it's a work in progress across nationally. I mean, what I put up is the ideal, but there's lots of places that aren't there yet. So we'll get there.
That's brilliant. And now here's another real world question. So in primary care, there are challenges around the pheno and lung function tests, as you mentioned, Stephen. So we've got the peak flow, but we're meant to have 2 objective tests to confirm diagnosis to add on to the asthma register. Any solutions?
Well, as I said, I think you have to be pragmatic. You know, what I really don't like is where people are denied a diagnosis of asthma who clearly got asthma because they've had asthma attacks, and you know they respond to the treatment and they're much better on the treatment, and we withhold putting them on the register, which is really something actually about QoF being a perverse incentive. And so, you know, if you need tests, and there are kids out there with uncertainty, or you know the parents want it, you know, lots of reasons, then refer to your local secondary care service, and they should be taking responsibility for getting it done. It is unsatisfactory, but it's a commissioning thing.
Yeah, and there is that element of real world, isn't there? And a quick question just around the data. I guess to you, Amintha, are there 1,708 attendances that you referenced? Are they all asthma attendances?
Yes, so we used asthma and wheeze as our discharge criteria. So it also captured the viral induced wheeze. And these patients all get what we call burst therapy when they come in through the ED if they're in an acute exacerbation, which is the same. But even if they don't have the name asthma, as Stephen is saying, they should still get 48-hour review with viral induced wheeze, because I mean, the main point is some of these children have also had dexamethasone or prednisolone. So on that day 2-3, we need to know, are they responding or are they not? So we haven't differentiated asthma versus viral induced wheeze. And as many of you know, there is, you know, the age-old time of saying, oh, you have to be 5 to be diagnosed with asthma is gone now. So we've taken that element out, and we're saying everyone who gets a treatment of burst salbutamol plus or minus steroids should be seen in this 48-hour hub. Thank
you. And a quick question for you, Stephen. Where do you get your airway models from?
A very, very nice pharmacist called Darush gave them to me, and I've been trying to Google to find out where he got them from, and I can't find it. So I might just put his email in the chat. and you can all email Darush and ask for lung models.
Fantastic.
I'm sure he'll be delighted.
And an age-related query again. At what age can we do spirometry and or peak flow? When does that become reliable?
It depends on lots of factors. Depends on the child, and it depends on who's doing the spirometry and how kind of experienced they are. Peak flow, 6, 7, you can get reliable results. At a practical level, 7 or 8, you can start to get really good reliable results. Same for spirometry, by and large.
Fantastic, thank you. And in a way, you've touched on this, Amita, but are we supposed to be reviewing children with allergic rhinitis and viral wheeze in the same way as we do for children with formal diagnosis of asthma, completing asthma templates and asthma plans? I'm not sure who would like to ask.
Yeah, I can say, maybe the others can add on. I think it's what you treat them with. When they come in, I can only answer for the 48-hour follow-up. If they've come in and they've needed treatment for an exacerbation, so if they've come in with allergic rhinitis and you're treating them with salbutamol, then they do need a review. Same with, as I've touched on, viral wheeze. We don't differentiate between viral wheeze and asthma. We do it on what we're treating them with. I don't know what you would do in the primary care setting if it was their 1-month review or not. I'll leave that to the primary care colleagues.
Stephen or Tanya, did you want to come in?
Not much to add to that. I think Amita's covered it.
Brilliant, thank you. And then the final hot topic of a question was, is there a place for virtual or in-person group consultation for parents of children with asthma, in trying to educate a lot of parents at the same time? And as a follow-up to that, would public health or school nurses be able to help in any way?
Well, I can just say I love it as a concept. I think it's a brilliant idea. Yeah, public health, why not? I mean, they actually asked us, our local public health, how they could support with the ask about asthma, and maybe trying to facilitate something like that would be amazing. So I like the idea.
Yeah, I think I agree. I like the idea. We've done some group consultations for parents and the children. I think that all these group consultations over the next few years, they're going to become the mainstay of long-term condition management, because there's a sense of efficiency, but also the way that parents and children answer their own questions is so powerful, and they find the solutions. And we've certainly, I think, in diabetes seen how useful that is. So yeah, I'm sure it will come in some form.
So I suppose, I mean, the adults, there's expert patient programs, aren't there? And so are there the similar thing for children and families?
Not that I've seen, but they should be.
There you go. So if something for feedback for those of you who are in strategic groups, it's a great idea, whoever it came from.
That's brilliant. Thank you. And in the final few moments, I just want to say a huge, genuine thank you to our expert speakers for sharing such insights and learning, and actually just inspiring us to improve our asthma care for our children and young people. The recording of this is being shared on the Ask About Asthma transformation platform. The link is in the chat. And we also just ask for your feedback. Again, it's just so helpful to be able to shape future learning. And we really look forward to any kind of feedback or ideas that you have. And it seems like we've already managed to inspire several rounds of spin-off work for people. And so just thank you so much for your time today. Hopefully we've managed to address a lot of the questions and issues that arose If there's anything that hasn't been addressed, we will be double checking the chat and we'll be able to reach out to you. But hopefully this has been informative and helpful. So thank you so much. I'll let you go now.